So just to be sure, you're here today to attend the training, the 3Ds. How do you differentiate between delirium, depression, and dementia? Next slide. And I'm not going to go over my learning objectives because of time. So Kelly, if you can move to the third slide, that would be here. Do you want to show the nothing to disclose? We just need to put this on that I have nothing to disclose, no conflicts of interest. And then if we can just move on to the third slide. So I really want to start with this slide because recently I got some feedback from some other audience that I gave it. Hey, we want to, I wasn't clear about what is the differential. So I said, let's start with this slide. And you will all be getting this information, this slide deck. So really, what is the difference between these three: delirium, dementia, and depression? And the things we are going to look at are onset, the course, the duration, consciousness, attention, motor changes or psychomotor changes, and whether this is a reversible or a non-reversible disorder. And so we are just going to take two of those and look at it in terms of onset. Delirium happens within hours to days. Dementia is very insidious. It happens from months to years. It develops. And depression can be acute, that it comes on suddenly after maybe a specific stressor or event, or it can be insidious and slow. So it can happen from weeks to months. So that's how we would distinguish between these three in terms of its onset. If you can look at reversibility, the last one, delirium is usually reversible. And we'll be talking about it very shortly. Why? Dementia is irreversible and for the most part progressive. And depression is also usually reversible. Yes, there are some depressions which are what we call intractable or refractory. You've tried everything, they still never totally go away, but for the most part, they are reversible. So I'm not going to go on every section of this. We will take a look at this slide again at the very end. Next slide. I also want to talk very briefly about age-friendly health systems or using an age-friendly framework. This actually comes originally out of Canada, but it is being adopted widely in the United States and advanced by the Institute of Health Improvement, IHI. And it makes perfect sense to me. And so I want to also begin my talk by really challenging you. Is your system of care, wherever you are, whether you're an aging service case manager or you work in community mental health or in a primary care setting as a nurse, is your health system age-friendly? And by that, I mean, do you follow this framework of what matters to the older adult? Medications, mentations, which would mean identifying and treating dementia, delirium, and depression, and lastly, mobility. So we are going to come back to this, but again, this is the 4 M's framework that I really want to advance. Wherever I speak now, I talk about this. And so I'll be asking you a question at the very end. So next slide. So let's begin with the presentation. I want to begin with a case study of Louise. She's 83 years old and she lives in a nursing home. Lately, she appears increasingly confused. She has been crying and trying to leave the facility over and over again. She goes to the door and rattles it. She's been needing more help with her ADLs and personal care, but often refuses it, because she's kind of confused. And the request comes from the nursing facility staff, please help us with diagnosis and management. Essentially, what's happening with Louise? Next slide. And supposing it lands on your desk, one of you, what's happening to Louise? Is she depressed? Because she seems to be crying a lot more. Is this a dementia or a worsening of her dementia because she seems confused and needs more help? Or is this a delirium? Again, it says she needs more help and she's confused. And so this is what we're going to unpack. How can you, as a clinician, a case manager in aging services, an RN, how can you help the nursing home figure out what's happening so that they can develop the most appropriate plan for Louise? So next slide. So we're just going to look at what's the difference between dementia and delirium. And why am I doing just these two? Because of Louise. And as you know, dementia is very common in nursing facilities. So what's the difference? Delirium is irreversible. That means you can reverse it. It is a confusional state characterized by acute onset. Acute onset just means sudden onset, which leads to disturbed consciousness. And there is an identifiable underlying medical cause, such as an infection, polypharmacy, multiple medications or side effects, recent use of anesthesia, sleep problems, electrolyte or metabolic imbalances. So the underlying cause is medical. Look at dementia. Dementia is irreversible. It's not going to go away. In fact, it's progressive brain disease, resulting in cell death and significant cognitive decline over the course of several years. And currently there's no cure. So you can clearly see there's a difference, correct? One is reversible, other one is not reversible. The one is sudden onset. That's now how dementia comes on. And delirium has a medical cause, while dementia is a brain disease resulting in cell death. Next slide. So here are the key features of delirium. This is straight out of DSM-5. Key feature is rapid and abrupt onset. So remember that when you see rapid and sudden mental status changes, think delirium. And how does it manifest itself? Impaired attention. The person cannot focus. They cannot shift or sustain their focus. So impaired attention, lack of awareness of the environment. Where am I? I'm confused. Is it day? I'm looking for my home. So there's reduced orientation. So that's the lack of awareness. And change in at least one of these cognitive domains: memory, orientation, language. Language essentially means they're rambling and unclear. And perceptual disturbance such as hallucinations. So the key features are rapid and abrupt onset, and then you have to have impaired attention, lack of awareness, and compromise in one of those cognitive domains. Next slide. So here I'm just kind of summarizing what they are, so that you know the difference when you see it. So sudden onset, fluctuating course, so it comes and goes. Inattention, very important. Disorganized thinking and altered level of consciousness. And we are going to look at all of these. Next slide. So who are the older adults who get this? So what's the prevalence? 10 to 50%, that is almost half of older surgical patients are at risk for delirium. 25% of general inpatient geriatric patients and 80% of ICU patients experience delirium. 26% of geriatric patients meet criteria for delirium in the ER. When you are sending people to the ER from, say, a assisted living or a nursing home, 26% of those older adults in the ER will have a delirium, which is, one quarter. And obviously there's high prevalence of delirium in people who are ventilated. So I just kind of wanted to give you a flavor of who gets it. Next slide. So delirium is associated with very serious dire outcomes. More disease, it increases your length of stay, whether it's in a nursing home or in an ER or in a hospital. It increases healthcare costs. It frequently leads to the person having to move into an institution if they had been living in their own home. And of course, increased death, which is that part, the last issue here, which is mortality. So yes, so it's a very serious thing. So DSM, next slide, DSM-5 further specifies what could be the cause of the delirium. DSM, by the way, is the Diagnostic and Statistical Manual, 5th edition, which we all use in behavioral health, okay? For some of you who may not have known that. So we specify whether it was induced by substance intoxication, substance withdrawal, whether it is medication induced, whether it's due to a medical condition, multiple etiologies. It could be all of those, substance withdrawal, medications, medical conditions. And then we say whether it is acute, that means it's come on very suddenly and it's lasting few hours a day, or it's persistent and weeks or months. And now you may tell me, Nirmala, you just said it's reversible and goes away. There is one kind of dementia, especially in long-term care settings where individuals get delirium so frequently. You may have heard the term or seen the term on the diagnosis, encephalopathy, which is kind of like a persistent delirium. So we also try to specify, aside from what is the etiology, whether it's acute or persistent. Next slide. So there are 3 types of delirium. One is called hyperactive delirium, which is not so frequent. Actually, here the patient will be very aggressive. They are screaming and yelling. They're pulling out any kind of IV or any other medication lines you have in their arm. They may be having visual hallucinations, maybe hitting, biting. So it's basically, they are very, very, kind of active. The second type is called hypoactive, which is actually the most common type. What are the signs of a hypoactive? They are essentially inattention and decreased awareness of the environment. The person is very lethargic. They are very withdrawn. They are kind of quiet and can easily be missed out on. So this is the one that we sometimes refer to as encephalopathy that I was talking about. And this actually has worse long-term outcomes, this hypoactive version. And then you have the mixed version where you can have both. So really the types of delirium are really categorized by the level of alertness and the kind of level of motor activity. And the names itself suggest that, right? Hyperactive and hypoactive. Next slide. But again, just a word of caution about hypoactive delirium. Remember I said the outcomes are worse and also mortality is very high. First of all, because these people can present as very depressed or that they have dementia. And that the likelihood of delirium may be totally missed. That means nursing home staff or mental health staff are thinking, oh, this is really a depression. Well, it's really a delirium. They also present as, I said, lethargic, withdrawn, apathetic. So they don't create a ruckus. And guess what? They sometimes get overlooked in a busy nursing home or a busy assisted living. And, oh, he's just quiet, but no, he may be seriously ill. And this is what hinders recognition and therefore the really bad outcomes that I referred to when you have hypoactive delirium. Next slide. And here are some common causes. It could be toxicity, which could be drug toxicity, toxicity because of interactions, with other drugs that you're taking. It could be withdrawal states. It could be traumatic injuries, infections, metabolic and endocrine problems, just dehydration or malnourishment, fecal impaction, intoxication of illicit and legal substances, just the number of medications you have, and yes, dehydration. So these are all some very common causes of delirium. Next slide. And so an assessment is very important. So, getting a good history and physical, looking at the entire list of medications, including any that are over-the-counter, herbs, vitamins, all of that. And then these are some of the kind of standard tests which are recommended. You want to look at, what is their blood oxygen level, their cultures to see whether there's any kind of infection, drug levels, whether they have substances in their bodies, or you're looking for medication levels, blood chemistry, B12, folate, all these are kind of some standard tests which are recommended when you're trying to get to the bottom of, what's happening to this person. For example, B12 folate, can cause like memory issues and stuff, and you can look like you have a dementia. So knowing what your B12 level is as part of your assessment, if you're a nurse practitioner or something, ordering that is really a good thing. So next slide, here are some risk factors. So if you already have a dementia or you have mild cognitive impairment, you're actually at greater risk for a delirium, just having dementia. Age, advancing age. If you already have a history of delirium and other kind of neurological problems. If you have multiple medical diagnoses, most older adults, at least in the United States, have 3 to 5 chronic illnesses by age 65, like hypertension, diabetes, COPD, depression. So, the more you have, the more at risk you are. Men are more at risk. And that if you have kind of chronic renal and hepatic disease, or your kidneys and liver are not functioning that well, it's easy for you to accumulate medications and other things, that can kind of tip you over very easily, especially if you are an older person with many of these risk factors. Next slide. And I'm not going to go over this slide, but you will be getting the slide decks. Here are some more risk factors for delirium. I just want to point out the last one because we're going to talk about that, visual or hearing impairment, which can actually lead to a delirium. And we're going to look at management at the end, but I'm not going to go over this. You will be getting the slide. Next slide. And really a word of caution about medications and delirium. Older adults in the United States consume the majority of prescription medications in the United States are consumed by older adults. And this is data like coming from Medicare Part D. Medication use contributes to delirium in more than 40% of cases. That means medications in themselves contribute to delirium. And then if you use psychoactive medication, it results in a 4-fold increase in terms of risk for delirium. And whereas if you use 2 psychoactive medications, it even increases it more to a 5-fold risk. So first of all, just medications in general, all kinds of medications. And then in particular, psychoactive medications put people at a really high risk. And I'm going to talk about one such medication. Next slide is lorazepam, which is a anxiety medication. Did you know that it is an independent risk factor for transitioning to delirium in an ICU setting if you are given lorazepam? And look at it. It is an important modifiable risk factor. So if we want to decrease the risk for delirium, we need to really look at how and when we are prescribing this lorazepam, because we can modify that risk by decreasing it, discharging that medication, whatever. But I wanted to point out to lorazepam as an independent risk factor. Many medications are a risk factor, but lorazepam in itself is an independent risk factor for delirium. Next slide. So be very cautious of these medications, which are called anticholinergic drugs. They are dangerous for older adults. And I call it that, remember the 4 antis: antihistamine, antipsychotic, antidepressant, anti-Parkinsonian. Out of these, the 2 are those psychoactive medications, which I told you, the antipsychotics, antidepressants, which actually have the 4- and 5-fold increase in risk. So kind of just remember, anticholinergic drugs are dangerous for older adults. And I'm going to be sending out a little later, we'll be talking about the Beers criteria. Next slide. And here I'm just giving you a list of medications which are associated with delirium. Remember, I said all medications are, but psychoactive in particular. But look at the list here. Gastrointestinal medications, whether it is for antiemetics or antispasmodics, cardiovascular medications, analgesics, allergies, sedatives, all of these are muscle relaxants. All of these put older adults at risk, medications in itself. And then when you kind of combine it with aging bodies, with liver and kidney dysfunction, with multiple medications interacting, it's no surprise that older adults end up with delirium. Next slide. And here is my question to all of you. Wherever in the world you are practicing, do you use the Beers criteria in your practice? And if you don't, we are going to send you a link to it in an email. Kelly will be sending out the Beers criteria, which is a list of medications which are developed by this gentle Dr. Beers. It is updated every year, periodically. The last one was 2019, which basically gives you a whole list of medications which are potentially harmful to use in elderly folks. And so we highly, highly recommend this as a best practice. Do you use the Beers criteria? And that's a question I'm asking all of you. If you do, please put it in the chat box. We'd love to see who are the people on our training today who use the Beers criteria. Next slide. So treatment of delirium is crucial. Failure to treat delays recovery, can worsen the older adult's functioning and health. So whatever functioning they had, it can deteriorate, and it actually puts them at risk for death. And it is critical to identify what is the underlying cause. If it is polypharmacy, if it is 3 medications that they're interacting, or they're at such toxic levels, whatever it is, you need to treat the underlying cause. Intervene immediately for urgent medical conditions, and then obviously ongoing monitoring. Then decrease all environmental factors that are exacerbating the delirium. For example, making the environment familiar, reorienting and assuring the person who's confused. Hey, you are at Fairview Nursing Home. You live here. This is Bend, so reorient and reassure. So that would be kind of decreasing environmental factors. And then putting in somatic interventions and looking at these medications, which we'll be talking about very briefly, very shortly. So how can you manage delirium? Next slide. Remember I said, look at the environment, adequate lighting, familiar objects, including clocks and calendars, so that you are able to orient the person. They have a foothold in space and time. I'm in Bend in Fairview Nursing Home, and then you have a clock which shows the time. I would say the old-fashioned clocks or digital, and a calendar, or a whiteboard on which you write today is Wednesday, April 9th, or whatever the date is. So those are easy interventions for anyone to do. Promote physical comfort and pain assessment. Check, are they in pain? Is their bed linen wet? What level is their pain well controlled? Assess all normal input. Check for their glasses. Are their glasses on when they need to look? Do their dentures fit well? Frequent reorientation. So all staff are frequently reorienting the persons. And good to have presence of family and friends, even if it means like photographs and familiar objects. And then obviously check for adequate nutrition, hydration, oxygenation, and sleep. Recently, someone told me that they went to do a PASAR evaluation. It came in, it's saying the person is not eating and has lost, 40 pounds, and maybe it's delirium. She went to do the assessment, and what she discovered was the gentleman was laying in a bed where the mattress was sagging. So he was almost to the floor. He couldn't sit up to eat well. And guess what? He wasn't eating because he couldn't, and the evaluation was simple, hey, get him a better mattress. He should be sitting up upright. He needs assistance with eating. That means you need to actually cue him or put the food in his mouth. And guess what? He's doing really well now. So I know that's kind of an extreme case, but really looking at why is the person not eating? Are they eating well? Are they well hydrated? Are they getting enough oxygen? And obviously sleep. Because it takes very little to tip someone who's already older and compromised. And currently, there are no drugs with regulatory approval for the treatment of delirium. Next slide. Kelly, can it move to the next slide?
Yeah, I just moved it to the next slide. Sorry, it went out.
Okay. Okay. My end, it hasn't moved. So that's okay. Okay, now I see it. So there are no drugs which are approved currently. However, Haldol. Many of us know Haldol. Haldol is the preferred agent for acute treatment, especially in ERs and stuff. Why? Because it has that, remember that 4 antis I talked about? It has a lower anticholinergic load. So that's why they use Haldol, though other atypical antipsychotics are also used in an ER session, in an emergency room. And obviously, we need to be very aware of the side effects of these drugs, which include extrapyramidal symptoms. And it also has some cardiac effects like prolonged QT intervals. And as you know, many of the newer antipsychotics also have a black box warning for long-term use. So, but really Haldol is the preferred agent, generally in a ED setting. Okay, next slide. And I've given you some information on the next slide about Haldol. You can take a look at it later. I'm giving you who all have recommended Haldol. And the good thing is Haldol can be administered orally, IV and IM. And it takes only like 5 to 20 minutes for the onset of action after IV administration. Obviously, the intramuscular and oral route take longer, but if you're giving it to someone through the IV, the onset of action is very quick. So I'm just giving you some of the consensus, the professional consensus statements on why the use of Haldol. Next slide. We also use second-gen atypical, atypical antipsychotics. They pose less risk for those extrapyramidal symptoms, sometimes called EPS, tardive dyskinesia, also called TD. But they have, elevated prolactin levels compared with first-generation antipsychotics, such as Haldol. And unlike Haldol, these are not available in an IV. We cannot give them IV, the second generation. Remember, IV, the onset of action is very fast, and that's why sometimes Haldol is preferred when someone is like very agitated, like when you have maybe the hyperactive type. So next slide. So again, I want to point out the differences in the two, delirium and dementia. The onset is very sudden and abrupt in delirium. It's insidious and slow in dementia. The attention is impaired. In fact, it's one of the primary symptoms in delirium, while it's normal in dementia. The consciousness fluctuates. You're in and out of consciousness, while it's clear in dementia. And your speech is then generally in delirium incoherent, disorganized, rambling. That's not the case in dementia. Next slide. And I already mentioned that there are barriers to recognizing delirium, and with sometimes it's just taken as a normal part of aging. But it is very critical to formally identify delirium, whether it is in a nursing facility or it's in the ER. That we really need to break this barrier down of recognition. Next slide. So this is the gold standard for assessment of delirium. It is called, the tool is called CAM, Confusion Assessment Method, CAM. It focuses on 4 key features of delirium, which we talked about when I showed you the DSM-5 criteria. The onset and the fluctuating course, the inattention, that means a person has a hard time focusing and staying on task, disorganized thinking, which is often expressed in this kind of rambling, disorganized language. And then the last is that unaltered level of consciousness. They don't know where they are, they're disoriented, they're going in and out. This is what this tool measures. Next slide. And here is the tool. And you're welcome to just download this slide when you get it. So you have to have 1 and 2, acute onset of mental status changes or a fluctuating course, and inattention. So you have to have those both. Plus one of these, disorganized thinking or altered level of consciousness. If you meet this criteria, you are using a best practice, it would mean this person has delirium. So it's called the confusion assessment method. Next slide. And here are some questions to ask when you're doing this CAM. For the sudden changes or fluctuation in mental states, you want to know what was their baseline. Is this different from their baseline? Did the abnormal behavior fluctuate during the day? That is come and go, increase or decrease in its severity. So you're asking the staff or family member. Inattention. Is the person able to answer a direct question with an appropriate answer? Can they stay on track, like while you're having the conversation with them? Do they have difficulty in focusing, or they're easily distracted and they're rambling? If the answer is no, also look for fluctuations in level of attention which can signal delirium. Then disorganized thinking. Is the person's speech, thoughts, rambling, unclear, unpredictable, illogical, irrelevant? You're asking them the question about what day is it, and they come back with something totally irrelevant. I am going to Africa to see a lion. It's totally illogical, irrelevant. It's disorganized. So that's what you're looking at in disorganized thinking. And lastly, that altered level of consciousness. Assess the person for alertness, vigilance, lethargy, remember the hypoactive, stupor, that they're stuporous, or coma. Stupor, lethargy and stupor is difficulty to arouse them. They're very drowsy, or they are, you know, they're drowsy but easy to arouse, or they're unarousable. So that's what you're looking at when you're looking at level of consciousness. Are they alert? Are they vigilant? Or are they lethargic, stuporous, or in a coma-like state? Next slide. So that's kind of a, you know, a bigger best standard screening tool. However, I want to talk about this ultra brief 2-item screener, also called the UB2, which you will be getting as an attachment. Kelly will be sending it out. So I'm really advocating for this use. It is called the ultra brief, and it's only 2 questions. It is administered by, you know, it says clinician administered. It could be anyone else who's, you know, knows how to do it. And there are just 2 items. Please tell me the day of the week. And the second one, please tell me the months of the year backward. Say December as your first month. Those are the 2 questions. Please tell me the day of the week. So today you would actually say Thursday. And then please tell me the months of the year backwards. Say December as your first month. So it would be December, November, October, and so on. So this is it. It's 2 items. How do you score it? If the person gets both items correct, the screen is negative for delirium. If one or both items are incorrect, this is a positive screen for delirium. For the months of the year backwards, answer is incorrect if one or more of the months are missed. So even if you miss one, it is incorrect. That means it is positive for delirium. Or the patient gives the wrong type of answer, you know, for the day of the week you ask them. And you only do 1 reread of instructions. All of that, you know, that's how you. A positive screen requires a more thorough diagnostic interview. The instrument developers recommend what we just went over, the CAM. But this is an ultra brief screener for any of you on this call to do. And we will be sending you the ultra brief actual screener, next slide, which kind of looks like this. Again, it is ultra brief, 2 questions. Please tell me the day of the week. And please tell me the months of the year backwards. Say December as your first month. And you can say, you know, a little bit slower if you want, but you don't keep rereading it, you know. Remember, inattention is a symptom. So if the person can't remember, we are concerned about attention. So I am highly recommending it for busy clinicians, for people who can't do the CAM, and you don't have to be like a licensed QMHP or anyone. If you work with older adults, this is a good tool to use when you see sudden changes in their mental state. Next slide. I have also included this screening tool. It is called the Visual Modified Richmond Agitation and Sedation Scale. Short form, it's called MRASS. And it is actually developed by the VA. I like it because it also gives you a pictorial depiction of how alert your person is. And if you can look, if you go, the downward arrow leads to decreasing consciousness. And the upward arrow increase agitation. And if you can look at the downward arrow, you know, it says wakes easily, wakes slowly, difficult to wake, cannot stay awake, unarousable. I have included the link there. I would highly recommend you check out that link, which is heartbrain.com/delirium/protocol. It comes out of the VA, and you will be actually getting this this instrument in the package that Kelly will be sending it out. I just like the pictorial. It also just helps me when I'm writing up my assessment after I do, maybe I use the, ultra brief screener, but I can describe, how this person is difficult to wake or they're unarousable. So I just wanted to include that for you. Next slide. So how do you prevent delirium? We talked a bit about it. Know your resident, patient, client, consumers' cognitive baseline. What is their baseline in terms of their mood, in terms of their cognition? Orient, avoid drugs, and involve in therapeutic activities. Sleep. Do you know how well your client sleeps? And how do you promote good sleep hygiene? Are there some changes you need to make in your environment, in your routines, in your nursing schedules? Do you wake up people at 2 a.m. in the night to check whether they need to go to the bathroom or you have to take some kind of vital signs? Those are all not promoting good sleep hygiene. Immobility. Remember the gentleman I said who was not eating and had lost 40 pounds? He was sinking in a sagging mattress, just laying there. He was not at all mobile. No one was making him get up and walk. So it is so critical to maximize mobility for all older adults, especially in long-term care or community-based settings. So maximize mobility. If you need to involve PT, get them going, because this is delirium prevention. Vision. Check on their glasses, check whether they need magnifiers, do they need light, more light, touch pads, whatever. Kind of optimize their vision. Hearing. Do they have earwax? If they do, remove it. Is hearing aid working? Are there some other kind of amplification devices you can use so the person can hear and is oriented? There's lots of research being done around hearing loss and cognitive decline. So really focusing on hearing is key. And then dehydration, early recognition that this person is not getting enough fluids. And the solution is simple. Just replenish that in however you need to, whether you hold the bottle, you give a straw, you watch them drink. I can't tell you how often it is dehydration. And that older adults, their tipping point, it doesn't take a lot for them to tip into something, some kind of pathology. Next slide. Again, I'm repeating some of the things I've said, so I'm not going to go over all of this, but really I want to emphasize how important early mobilization activities are. If you don't already do it, please create a mobility plan for all of your residents or consumers. Create a mobility plan. Every day they're going to walk for 15 minutes or 30 minutes, or a caregiver is going to take them outside and help them walk, or whatever it is, strength exercises, flexibility, like sitting in the chair, yoga, or whatever. Creating a mobility plan. I cannot emphasize that more. In fact, I keep telling people, all the literature says that lower leg, muscle strength is the holy grail of aging. That once you lose mobility, there is a steep decline, not just in physical functioning, but also in mental functioning. So I really want to emphasize that. And the other one was pain management. I can't tell you how many places I've gone where people have a dementia and they are delirious and they are on PRN pain medication. What does PRN pain medication mean? That the person has to tell you, I need medication. When you're delirious, when you have a dementia, it's hard for you to, first of all, assess your level of pain and ask for medication. So when do you give it? It is way better to have it scheduled. Work with the nurse practitioner or with the doctor or physician to actually schedule the pain medication. Next slide. Again, I just want to emphasize the importance of mobility and sensory inputs. You know, we tend to remember the 4 M's. We talked about the 4 M's of age-friendly systems. One of them was mobility. And so my challenge to all of you on this training who work with older adults, do you work with your client or encourage them to have a mobility plan? Not just have a plan, but that you're actually monitoring it. Have they had a recent hearing and assessment, a revision assessment? Have their ears for wax been assessed? And are their assistive devices actually in good working condition, including eyeglasses and whatever else? So basically the summary points, it is common. It is an acute illness in people. It is associated with very adverse outcomes, frequently death. It is characterized by sudden recent onset and fluctuation in attention and drowsiness linked to triggers. Those should be thought of as triggers. Routine cognitive assessment. So it's good to have a baseline cognition so you know when things are different. And that delirium can be prevented from all of the things that I suggested earlier. And some of them are really simple, those environmental changes we talked about, orientation, reassurance, and maximizing mobility. Okay, so with that said, I want to move on to depression as our next D. If you remember, we showed the first slide of what the differential is. So I'm just giving some basic information here. Depression is a medical illness. It's not the blues. It's not sad feelings. It's not a part of grief. It's not a part of normal aging. And by the way, according to the World Health Organization, it is the leading cause of disability worldwide for all age groups. So not just older adults, leading cause of disability. Next slide. Depression is persistent, pervasive. That means it affects all areas of your life. It's very intense in terms of its severity, and it affects all areas of your functioning. Next slide. And here is the DSM-5 criteria for depression. You need to have 5 or more of the following present for you to have what we call depression. Depressed mood most of the day, diminishes and hobbies, significant weight loss or gain, sleep problems, whether you're sleeping more or sleeping less, psychomotor agitation or feeling the opposite, slowed down and lethargic, fatigue or loss of energy, feelings of worthlessness or guilt, diminished ability to think clearly or concentrate or make decisions, and recurrent thoughts of death or suicide, or suicidal ideation, wanting to die. So this is right out of DSM-5. And you have to have 5 of these symptoms present during the same 2-week period. So it can't be that it's happening 1 week, then it all goes away, and then it comes on 4 weeks later. So you have to have these 5 symptoms, and they need to be there for a contiguous 2-week period. Okay. Next slide. And then there are many different kinds of dementia. Some of them are new names, or what we call classification or nomenclature, which came due to DSM-5. What we used to call dysthymia, which used to be like a minor depression, not such a severe one, is now called persistent depressive disorder. There's one called menstrual dysphoric disorder. There's a depressive disorder due to medical conditions. So I'm just giving you what are some other kinds of depression now included in DSM-5. Next slide. Now, DSM-5 did something different. They excluded bereavement, grief.
Nirmala, this is Angela. We're having some trouble with your audio. You might want to start over. Nirmala, can you repeat the bereavement piece?
So DSM-5 excluded grief. I am repeating it right now. So bereavement was excluded. Hello, can you hear me?
Well, you cut out there for a while.
Hello?
Nirmala, can you hear?
Actually, the connection is strong. Can you hear me now?
Well, unfortunately, when I can hear you is when you're asking the question, can you hear me now? So I didn't hear a whole lot of your coverage on the bereavement piece. But if you want to move on, I think that will work.
So essentially, bereavement is not included in DSM-5 as a separate category because it is considered just an other trigger stressor like other stressors. Next slide. However, depression does differ in older adults. Can you all hear me speak?
Yes. Yes.
Angela? Yes. Okay.
Yes.
So older adults often present with both anxiety and depression as co-occurring. Secondly, very often when they present as depressed, cognitive abilities are marked or they dominate the picture, such as they have problems with concentration and memory, which can then be mistaken for a dementia, but it's really a depression. And they have more complaints about aches and pains rather than about a sad mood. So you can see how quickly it can be misdiagnosed or not detected. Next slide. So what happens when depression is not detected or not treated? You have overall very bad health outcomes on the whole for older adults. More hip fractures, myocardial infarct, cancer. These are all diseases where there's high rate of what we call comorbidity with depression, and which can then lead to death. In fact, for myocardial infarct, depression is a significant predictor of cardiovascular morbidity and mortality. That means if you have a MI, and you have depression, it's a predictor that it will get worse and you may even die. So how important it becomes that in cardiology, in specialty care, that you are actually screening for depression. Next slide. So depression is bad for your heart health, especially if you're older. Baseline depressive symptoms are associated with cardiovascular disease. So it's a very serious, so it has very serious health impacts. And I just wanted to bring that to your notice because in America, cardiovascular disease is the leading cause of death, followed by cancer. And last year it was COVID-19. So I really want all of you who work with older adults who have cardiovascular disease, who have heart disease, screen for depression. Next slide. I also very briefly want to talk about suicide in older adults. It is in the top 10 causes of death in the United States is suicide. In Oregon, it is It is about the 8th leading cause of death for older adults. And the group that has the highest incidence is actually white males over the age of 85. So very high prevalence of suicide in older adults. And one of the reasons is that they tend to choose more lethal means to die by suicide. Most frequently, it is firearm. So we are doing a lot of work in Oregon and actually work across the country to how do we prevent suicide? Next slide. Here are some other facts about suicide. Next slide. Of suicide. Firearms are more, how sad is that fact? 64% of people who died by suicide, that means older adults, saw their primary care provider within a year of dying. That means they were in their primary care doctor's office and nobody asked them how they were, whether they were depressed, how were they feeling emotionally, and that 12 months later, they died by suicide. And all the research shows that reducing access to firearms actually lowers suicide deaths. So next slide. So what are some risk factors for depression in older adults? You have a history of depression. You have severe psychosocial events or stressors, such as we just talked about grief, like death of someone, marital divorce or separation. You have a medical condition, or more important, a recent serious illness diagnosis. You have a family history. You are female, so women are at higher risk for depression. You're experiencing a loss of independence. You have some new acutely disabling condition like a stroke, or you have a severe new cancer diagnosis, and you have some long-term physical disability. Next slide. And here I'm just giving you some other risk factors. The one I want to point out is feeling lonely and feeling isolated, which means really reduced support systems. You know, that you really don't have that kind of strong social network. And I've put all, heart disease, cancer, diabetes, these are all risk factors for depression. Yes, diabetes too. How many of you routinely screen your client who has diabetes for depression? And did you know people with cancer, about 55 to 60% also have a co-occurring depression, and they have a 7 times higher incidence of suicide and suicidal ideation in cancer, especially in the first year after diagnosis. And I give a whole talk about suicide and serious illness. So next slide. So what's the barriers to treatment? For depression, why are people with older adults not getting identified? Remember I said that, the people who die by suicide, almost 97% had a psychiatric diagnosis. Most often it was a depression. And yes, people think it's just a normal part of aging, but that is wrong. Here are the myths, next slide, that we want to bust. As you get older, it's natural to be depressed. Nope, that's a myth. You have to learn to live with depression. It's a character flaw. Just pull yourself up by your bootstraps. You just need to get rid of your negative attitude. Those are all the myths, especially in this current cohort of older adults, where it's still very, very stigmatized to talk about your emotional health. Next slide. And we went over this, what are the differences, in presentation of depression in older adults. Physical complaints dominate. There's more frequent aches, pains with really no clear underlying cause. They are more withdrawn and apathetic. they have some loss of self-esteem. But what is really prominent is that I can't concentrate, I can't remember, I can't make decisions, or that's what people are reporting. Next slide. Depression in primary care. Primary care physicians and providers are often the first and many times the only clinicians who are seeing this older person with depression. Because guess where older adults go for their treatment, even for their emotional health, is to primary care, not to specialty mental health settings. Next slide. And the sad fact is that in primary care settings, it is under-detected, under-reported, under-treated. Depression is. And I told you that once you don't treat depression, it has a cascading effect on all your other health diagnoses and on your functioning. Next slide. I'm not going to go over this, but we recommend having a depression care manager in primary care settings. Because of a lack of time, I'm not going to go over this slide, but you will be getting this. Next slide. So if you're seeing someone in primary care, this is what we would suggest. Severely depressed patients should be seen weekly, and less severely 10 to 14 days for the first 6 weeks. Give them reminders of follow-up visits. Give them a call, give it to them in writing. Check that they're regularly filling their medications, and not just filling it, but actually taking them. And when it's more complex, refer them out to specialty health. Next slide. And here are some barriers to screening in primary care and other settings. Ageist assumptions that, hey, they're older, what do you expect? Of course, you'll be depressed if you're 80. Failure to recognize the symptoms as a depression. Lack of knowledge. Hey, what screening instrument should I use? And sometimes there are these masking of symptoms because they have so many other chronic medical conditions that they kind of get masked, and you tend to concentrate on those physical symptoms then. Next, when should you refer to specialty mental health if you're seeing someone in a family practice setting who have severe symptoms, who have high suicide risk, who have a lot of medical, psychiatric, and substance use comorbidities, and then they're failing to respond to the treatment that you're offering in the primary care setting? Then it's time for you to either consult or refer out. Okay, and here are the screening tools that we recommend. You will be getting them. Kelly will be sending them out, the PHQ-9. I'm not going to be sending out the depression geriatric depression scale, but I'm giving you some other tools too. And the Columbia suicide severity rating scale is only for suicide, so it's not for general depression. Next slide. I have put here what we call the PHQ-4. This is a valid ultra brief tool for where you look for both anxiety and depression. Remember, I said, often in older adults, anxiety and depression co-occur. And so this is a very fast tool, which is only 4 questions. If they're positive, then you obviously go on to do the full test. Next slide. I'm giving you, how this tool has been validated, and also look at it. A score of 3 or greater on the anxiety subscale represents a reasonable cutoff point. A scale of 3 or more is positive, and then you should then complete the larger tool, which is called GAD-7, or the Generalized Anxiety Disorder Scale, 7 questions. So I'm just giving you where this was validated and how you read, interpret the score. Next slide. Because of lack of time, I am only giving you what are some psychotherapy treatments which are evidence-based. And the gold standard is a combination of counseling and medications. So there's one kind of treatment called interpersonal therapy, which are very good for older adults. Other one is CBT, or cognitive behavioral therapy. Next slide is behavioral activation, which through our initiative, we've really been advocating for its use. And the last one is problem-solving therapy. If some of you are familiar with the depression program called PEARLS, they use problem-solving therapy. Any of you can be trained in this, and this is the best practice for counseling or psychotherapy for older adults. Any of these four, but combined with medication. But what happens is older adults, for some reason, do not get referred for psychotherapy. That again is a bias. It's a provider bias. They do just as well and benefit just as well from psychotherapy. Next slide. There's a whole bunch of medications. I'm not a prescriber, but I've put the names of the medications which are used in combination. I just want to point out esketamine, which was approved in 2019, right at the bottom. Next slide. I also want a word about ECT, which stands for electroconvulsive therapy for older patients with major depression. This was a systematic review, and I've given you my source. They showed that ECT appears to be an effective and safe treatment for older patients with major depressive disorder. So I have a quick case study, which I would like to read. Next slide. Mrs. G is a 75-year-old woman who lives alone in her apartment in New York City. Her husband died recently, suddenly. Her 2 children are alive and live out of state. Both of her sons maintain weekly phone contact with her and usually visit about once a year. Mrs. G had been doing quite well until about 6 weeks ago when she fell in her apartment and sustained bruises, but did not require to go into the hospital. Since then, she has been preoccupied with her failing eyesight and has decreased her walking, her ambulation. She's afraid of falling. She does not go out shopping. She states she doesn't enjoy going out anymore and feels very sad and teary. Mrs. G states that her shopping needs are less since she's not as hungry as she used to be. Here are my questions. What risk factors might account for Mrs. G's symptoms of depression? You can put it in the chat if you would like. What are her depressive symptoms? And what might be some treatment strategies? So Kelly or Angela, I don't know whether you see any answers. Just a few.
Okay. I think folks are thinking it through right now.
Okay.
So
what might be some risk factors for these symptoms? I can see someone has put down what are the depressive symptoms. They put she's not eating, she's crying. Risk factors is her recent fall, her isolation, lack of social support. I'm seeing all of that. Also, her death of her husband, sudden death 2 years ago. Those are all risk factors. Symptoms someone wrote about not sleeping, she's crying, she's not eating, not eating a lot, she's fearful all the time, which is that anxiety because she fell, and then a lack of mobility. And then what are some treatment strategies? I'm curious to see what you'll suggest for treatment. Do you all see anything, Angela and Kelly? Okay, someone said engage her in fall prevention. Absolutely. Do some fall prevention interventions like auditing her home for safety, maybe putting her on some low exercise program, whether it is someone coming in or or maybe making that a possibility for her to go out to a program for strength and flexibility. It could be getting her Meals on Wheels because she doesn't want to go and shop. Someone said PT, OT for strength for her mobility. Great, even connecting her to some social resources, like some friendly caller or social group, or a friendly caller, a telephone contact with someone who calls her every day just to chat, or adult day services, Sunshine Line. Lots of great resources. I'm so glad no one jumped to let's put her on medication because there were lots of psychosocial interventions for Mrs. G. So thank you all. So let's move on to depression. I really need to move fast. We are moving on to dementia, which is the last D. We already said it's a brain disease. It's progressive, it's reversible, there's no cure, and it's in the top 10 leading causes of death in the United States with no cure. Next slide. Dementia is an umbrella term, and under that term, you have different kinds of dementia, such as Alzheimer's disease, vascular dementia, frontotemporal dementia, Lewy body dementia. So dementia is the umbrella term. Next slide. In the United States, close to 6 million people live with dementia. In Oregon, we have close to 70,000 people with dementia. 2/3 are women. Next slide. 13.8 million people aged 65 and older are projected to have Alzheimer's disease by 2050, which is what? 30 years away. Actually, 29 years away, which we'll be doubling, more than doubling the number. Currently, it is, I told you 6 million. Imagine double the number in 30 years. Next slide. And look at these sobering facts. 82% of primary care providers say they are on the front lines of providing dementia care. So they're not going to neurologists at the university hospital or to some special geriatrician. It's primary care physicians. 50% and providers like nurse practitioners and physician assistants. 50% of primary care physicians believe that the medical profession is not ready for the growing number of people with Alzheimer's disease and other dementias. Did you know in Oregon, there are only 62 geriatricians 2 years ago, 62, not 602, 62. So we have a lot of work to do, correct? To get this training out to primary care providers. Next slide. This is what DSM-5 considers to be a dementia. Now we use the term neurocognitive disorder and we qualify it as major or minor. It is a decline from a previous level of functioning in one or more of the 6 domains: executive ability, language, learning and memory, perceptual motor, your social cognition or your social intelligence, and your attention. So you have to have a decline in one of these areas or in more than one area to qualify for a diagnosis of dementia. Next slide. So this diagnosis really interferes with your independence in everyday activities. Okay, it's not just a diagnosis on a paper, but it actually interferes with your ability to live independently, to drive a car, to take your medications on a regular basis, to know whom to call in an emergency. These obviously these deficits don't have to be due to a delirium, and they're not explained by any other kind of mental disorder. Remember, the 4 M's of age-friendly health systems is mentation. So you're ruling out, is this delirium, is it depression, is it dementia? And what we are saying is, what I'm talking about now is dementia. Next slide. I look at dementia as a stool with 3 legs. The 3 legs are cognitive decline, functional decline. Remember, cognitive decline means your brain functioning declines. Functional decline is where it impacts your functioning, your ability to dress up, your ability to cook a meal, your ability to drive a car, your ability to balance your checkbook. That is functioning. And then it also has a behavioral impact, that it affects your behavior. You could be agitated, you could be spewing out filthy words, you could be disinhibited, and you're doing sexually inappropriate things. So it also has a behavioral impact. So it has a cognitive, functional, and a behavioral impact. So next slide. Memory means you cannot learn new things and you can't recall what are those new things you've learned to live an independent life. Language, by language, next slide, we actually mean cognitive language. So it's not that you can't speak because of a stroke. Sometimes this is called aphasia. Basically means you cannot communicate because of brain dysfunction. So you've lost that language ability to actually string together phrases in correct grammar and syntax and communicate what you need, or you can't understand when a caregiver is talking to you. Can you imagine having that as a problem? So these would be some next slide symptoms of aphasia. You speak or you don't make sense when you speak. You can't recognize words. You can't understand people's conversations. You write down sentences that make no sense. Those should all be red flags that this is aphasia, or what we call, cognitive language problems. Executive functioning is your ability to, next slide, to plan, organize, control your impulses, helps you sequence things to complete a task, helps you regulate yourself, helps you start a task. We call that task initiation. That's all part of what we call executive functioning, which is, by the way, a cognitive domain embedded in your brain. Next slide. And so how does it impact your functioning when you have a dementia? It impacts your activities of daily living and your activities of daily living. And so next slide. So ADLs are your ability to dress, bathe, toilet, eat, ambulate. These are simpler tasks that really require less planning, But look at the next slide, which is IADLs. They in shopping, cooking, transportation, budgeting, medications. All these tasks require multiple steps, and they are higher level activities of independent living, which really get affected in a very dire way with dementia. Next slide. Here I'm just giving you all the different kinds of dementias. We are not going to go over them. The most common type in the United States and in Oregon is Alzheimer's disease, followed by Lewy body. But we've all heard of frontotemporal. We've heard of vascular, which generally comes stroke, HIV, Huntington's disease, Parkinson's. So these are all the different kinds of dementias. Next slide. I am, unfortunately, because of time, I'm not going to go over this next slide, the difference between normal aging and dementia, but I'm going to let you do it. You will get it. You will get this, so you can take a look at it when you get it. And next slide. All of these dementias are brain diseases, remember. So each one has a unique fingerprint. There are some kind of rogue proteins which accumulate in the brain. I'm just giving you the 2 rogue proteins for Alzheimer's disease. They are called beta amyloid and tau. which cause the damage to the brain, which are generally these plaques and tangles. What happens is these proteins accumulate in your brain. They're kind of like a sticky substance, and they cause those plaques and tangles, which lead to cell death. So each of those dementias I showed you has a unique fingerprint. That means if we were to do a autopsy of the brain after someone died, we can actually tell by the cross-section definitively what kind of dementia was had. So next slide, please. Not going to go over all of this so because of time, but I want to move to the slide which says symptoms. Next slide. Here are how it will manifest itself. Poor judgment, difficulty learning new things, difficulty performing simple tasks, like putting on your shirt and buttoning it because you've forgotten how to do it. Challenges in planning and problem solving, memory loss, which disrupts daily living. That's why you get lost in your neighborhood, because you can't remember the way back. Okay. So next slide, along with these symptoms, we also have another set of symptoms called neuropsychiatric symptoms, also known as behavior challenges or behavioral and psychological symptoms of dementia. Next slide. And if you know the disease, Alzheimer's disease, next slide, is named after Dr. Alois Alzheimer's. And his first patient, her name was Louise. She came to him because of hallucinations, those neuropsychiatric symptoms of dementia. At that time, it wasn't called dementia, but that was the first patient of Dr. Alzheimer. Was really a woman who had neuropsychiatric symptoms. Next slide. So what are these neuropsychiatric symptoms? Next slide, because I think that's when we get the most referrals for consultation. They're almost universal in dementia, unfortunately. These symptoms cause caregivers and people with dementia a lot of stress, and impairs their quality, not just for the person with dementia, but also the caregivers. These are actually these are considered psychotic symptoms. Look at in Alzheimer's, almost 30% of people will have it. Lewy body, 75%. Parkinson's disease, 50%. Vascular, 15%. Dementia, 10%. So it's almost universal. Next slide. And I'm giving you a flavor here of what these symptoms look like. Hallucinations. Perception like experience that occurs without an external stimulus. So it's not really there. And a delusion is a false fixed belief. For example, I hear someone talking to me in my head. People are talking about me. Someone is stealing my things from my room. Or there's a cat walking on my window. I see my parents from the corner of my eye. There's a new person who lives in my basement. These are real hallucinations and delusions that I've put up here. Next slide. And we know that dementia, typically family caregivers take care of people with dementia. Next slide. So common delusions in dementia are, you're stealing my things. No, please go back one. Abandonment, you're going to abandon me. You're not my spouse, you're an imposter. They don't recognize. It's not that they don't recognize you. This is called the Capgras syndrome, where they really think you are not your spouse, that you're actually someone sinister, or accusing you of having infidelity or having an affair. So these are very common delusions. I wanted to kind of give you a flavor for them. Next slide. And I like this slide because it gives you the cluster of symptoms. And, what is apathy, what is aggression, agitation, depression. All of these come out of dementia. So I'm going to let you take a look at them when you get the slide. Next slide. So I just talk about complex symptoms of dementia: apathy, agitation, wandering or wanting to leave, day-night confusion. We've all heard of sundowning, hoarding things. We just talked about hallucinations and delusions, which are almost universal. Impulse control problems such as undressing, sexual disinhibition, touching caregivers inappropriately, irritability, and that vocalization and calling out, all times of the day and night, kind of, what I'm referring to when I call calling out. Next slide. I'm not going to go over this slide, but you will be getting it. For all of you who work in long-term care, this is a really good algorithm to use in your facilities. So next slide, we talk about these behaviors, as challenges. And we want to really be sure to say that behaviors are really a sign of an unmet need. And it's up to us to figure out what is being communicated by this behavior. Remember, we talked about memory problems and language problems. If you're experiencing that, the person cannot communicate what they are feeling. It comes out in their behavior, whether they're agitated or afraid or screaming and biting you. It's up to you to figure out need is not being met. And I always tell my client, family caregivers to kind of repeat this, they're doing their very best. This is the best they can do. And that we are the people with the brains, functioning brain. Next slide. I also talk about creating a supportive environment. This is taken from Teepa Snow, for your clients or residents. Does your environment meet the 4 Fs? Is it friendly, familiar, functional, forgiving? And the 4 S's? Is it a sensitive match, a social match, and a selfless match for your residents, wherever they, sometimes we focus, next slide, we focus so much on care, medical care, that we forget to focus on well-being. And these are the 7 areas of well-being. I'd love for you to look at number 7, joy. Number 6, growth. Number 5, meaning. Number 4, autonomy. How are you promoting that in your programs? Joy, growth, meaning, autonomy. What does your client get up every day for? What meaning and purpose? What opportunities for growth and development are you giving your clients? How do you support autonomy, even in institutional settings like nursing facilities? Next slide. And I'd love to refer you to the Maslow's hierarchy of needs. Unfortunately, we don't have time to go over it, but we tend to do a good job with physiological and safety levels, which are at the bottom of the pyramid, but not so well on the next 3 levels, which is love and belonging, esteem, and self-actualization. So I challenge you all today, if you're working in a setting, first of all, think about the 4 M's framework, and then look at the Maslow's hierarchy of needs and say, am I meeting Mrs. Jones' needs based on this pyramid? Or am I just doing the safety and the physiological needs? If you are only doing that, then you need to challenge yourself and your organization to really look at how else can we meet the needs on those higher levels of the pyramid. Next slide. How do you help fill your clients' days with meaning and joy? Teepa Snow talks about 4 activities, levels of activities that make us human and feel valued, productive, and purposeful: work, leisure, self-care, rest and restoration. If you have someone sitting in a wheelchair in a corridor all day long, are you filling his day with meaning and joy? If you have someone slumped in front of a TV all day, are you filling the day with meaning and joy? So I want to kind of provoke you into thinking, what am I doing with my client? Next slide. And I talk about it takes two to tango, and it takes two to tango. Next slide. All people need to be needed. Next slide, please. All people need to be needed. Nurturing is a critical part of a life worth living. Dementia steals away roles and responsibilities that make us who we are. How many of you look at your resident as a nursing home resident as opposed to who is that person? Have you created a one-page profile? You actually know the person. Activities being of people with dementia. Find out what matters to you. That is one of the first M's in the 4M framework. Create a plan for purpose. And remember who has the healthy brain. Next slide. And take a moment as a caregiver or as a mental health specialist working with people with dementia. Next slide. Walk in their shoes. Walk in your residents' shoes for even a half hour. So these are poor target symptoms for medications, wanting to leave, pacing, those vocalizations, apathy. They are not good symptoms for medications. Next slide. However, anxiety, sleep problems, hallucinations and delusions, irritability and agitation, these are all good symptoms for medications. Next slide. And again, I'm going to let you look at this slide when you get it. Again, this is an algorithm for how you can manage those behavior challenges that we've been talking about. Next slide. And it is very important to get an early and accurate diagnosis for dementia because it helps you plan for it, plan for the future, helps your family plan for the future, and helps you understand what you need to do. Next slide. I'm not going to go into this, but suffices to say that if you have an early onset dementia, it is very good for all of you to also advocate for a driving assessment for your client. Next slide. Here are the medications for dementia. You may have heard of them. They are called cholinesterase inhibitors. They do not cure the disease. There is no cure for dementia. They only kind of stabilize your cognition for a little while and can maybe prevent institutionalization for a year or so. You may have heard of Aricept, Exelon. Those are all cholinesterase inhibitors. And then we have an additional medication called Namenda, which is different than a cholinesterase inhibitor, and generally they are given in combination. So all of you who make referrals for challenging behaviors, I always ask the question, is your client on a dementia-specific medication? If they're not, check on it, check why that has not been prescribed. Next slide. Here are some screening instruments that we are advocating. We are advocating the use of the slums now because it is free to use. I like the Montreal Cognitive Assessment, but you have to go through a training process, which costs about $125. While slums is free, you will be getting a copy of the slums. Kelly will be sending it out to you. Next slide. I just want to show for busy people, clock drawing in itself is a good brief screening tool. If any part of the clock is wrong, it should trigger a full assessment. I'm very sorry we don't have time to go into it, but next slide, I've given you how to give the clock drawing. and how you need to decipher the score. Basically, you tell the person to draw the hands of the clock and to show 10 minutes past 11. Any mistake is considered that the person should go on for a full-fledged assessment. And then we also, next slide, we also do something called the verbal fluency test. Again, you ask the person to give a list of animals in 60 seconds, or letter or words beginning with the letter A, for example. Your hope is that they're able to give more than 17 such words or animals in 60 seconds. Anything below that, cutoff is 14, would indicate that they have some kind of a cognitive problem and should be tested further. Next slide, I'm also advocating for this approach called the DICE approach. It comes out of Johns Hopkins and California and Michigan, where they developed this tool. DICE stands for describe, investigate, create, evaluate, where all of you who send reports for challenging behaviors, this is a very good tool to use and develop, called the DICE approach. And on the next slide, I'm actually explaining how you actually write a DICE report. You describe the problem, you investigate the problem, you create a plan, and then you evaluate, did it work? And so this is an evidence-based approach. Next slide. We talk about non-medication approaches. Always start with non-medication approaches. Don't jump to your Haldols. First, try everything with non-medication approaches and see if things improve with your resident. So I'm going to, next slide, I'm going to read a brief study, a case study. Mrs. D is a 98-year-old woman who lives in a nursing facility with a diagnosis of Alzheimer's disease. She comes frequently to the nursing station and appears very upset in the last few days. She tells you that she's looking for her mother and asks you to help her. You start walking with Mrs. D. What strategies would be most helpful? You would use reality orientation in the hope of reversing her cognitive loss, telling her her mother died a long time ago. You attempt to distract or redirect her to a pleasurable activity such as singing or eating, or you ask her to help you with a small task such as maybe folding laundry, and that later you will look with her for her mother. So what would you recommend? You can put it in the chat box, and Kelly and Angela, maybe you can look at it. We don't want to spend a lot of time because I have 2 more slides to quickly go over.
Yes, we have.
Someone said redirect to a fun task, which would.
Sorry, I spoke over you.
Someone said number 4. Someone said number 4. Several are saying number 4. Number 4. Number 4. I would say you can do either number 3 or 4. Okay, but definitely not number 1 and definitely not number 2. So thank you all. Next slide. Again, I'm ending with the slide we began with. I'm hoping, I know we were a little rushed on the depression, but I'm hoping that you now know the difference between delirium, dementia, and depression. And my next slide is what I'd like to conclude with, that depression is a mood disorder, okay? In DSM-5, it's considered a mood disorder. Dementia is a brain disorder. In DSM-5, it's considered neurological. And delirium is a medical disorder. So if you take anything back with you, at the very least, remember depression is mood, dementia is brain, and delirium is a medical disorder, which will give you some ideas about where do you need to turn next in terms of processing and evaluating it. And my last slide is a reflection for all of you today. after today's training, what are you going to do differently? What is one practice change you're going to make? And how many of you would like to use the age-friendly 4M's framework? So take a moment to think about this. And I know we kind of rushed through things. Kelly and Angela, are there any questions?
Yes, we do have some good questions.
And you can take my slideshow off.
Okay. Thanks, Kelly. So from Lisa Reuter, how long does delirium typically last?
It depends on how quickly it's detected and treated. You know, there is that persistent type I said, which is kind of common in nursing facilities where it kind of just lingers on. But as soon as the medical issue is treated, it gets resolved.
Okay. So as long as you get to it in time, you have the chance to reverse, but then there are situations where some people never have that resolved, correct?
And very often it is undetected and unrecognized. So it lingers on, and
right.
People get all kinds of wrong diagnoses.
So from one of our anonymous attendees, we have a situation. This is an interesting tidbit. She or he writes, it has been recently reported that Columbus Zoo Director Emeritus Jack Hanna has been diagnosed with dementia, now believed to be Alzheimer's. The reports say that he deteriorated rapidly. Would you recommend further screening for delirium or further screening in general?
I would say further screening in general. You know, I don't know what the rapid deterioration is, but you know, who did it, what. So I would say a thorough assessment of everything, including dementia and delirium.
Okay, thank you for that. And then Lisa Reuter again. Lisa writes, I thought falls was the #1 leading cause of death for the aged. Is that related to cardiovascular? So we might need a little bit.
No, falls is not the #1 cause of death. In America, overall in the United States, across the lifespan, cardiovascular disease is the #1 cause of death, followed by cancer. And then last year it was COVID-19 was #3. Falls is not the #1 cause of death. However, 1 in 3 Oregonians fall. It's the leading cause of injury for older adults. It means you fall and hit your head and you die. So it's not the leading cause of death, though.
Aha. Great clarification. Great questions, everybody. We don't have any more questions written out in our Q&A box, and I don't see anything in the chat. So it could be time to wrap us up, give you instructions again on how to receive your CMEs. You will all get the presentation, the PowerPoint. We've just decided that because some of you don't need CMEs, you don't need an EADS account, that it would be beneficial to you if we just send them out in a mass email. So everybody's going to get the PowerPoint today. And then if you need your CMEs, again, 81HUGS. Just cross-check me, Kelly. 81, correct? 81HUGS. Hugs with an S.
Yes, 81HUGS.
Okay. Let us know if you have trouble setting up your EADS account. Let us know what we can do in future, what topics we can bring you that would help you out. And again, as always, we thank our presenter, Nirmala Dhar, social worker extraordinaire.